if you want to kill yourself, don't go from here.
And the patient had chronic cocaine use, and she had developed a very large oral nasal fistula. And so anything she would drink would come out of her nose.
He had a drug addict patient who used cocaine and nose collapse.
And as you know, in the Middle East, and there's a lot of organ sales. Kidney sales is very popular.
Yeah, working with kids, I always worry when I refer somebody to oral surgeon.
So I recently had a patient, went down there for implants, and they all failed. I mean, look at my smile, it's beautiful. I said, yep, your teeth are moving.
Dubai, Turkey, and then you hear horror stories.
A lot of people go to Mexico to have veneers done or braces done. Sometimes it works out great.
It's already bone loss and everything. Failing implants is no joke.
That people look like the Predator.
Welcome to the Ask the Dentist podcast with Dr. Olga Dolghier, where your smile meets your overall health.
So today I'm extremely excited because finally I have an oral surgeon on my podcast. This is Dr. Vishtasb Broumand. He is owner and founder of Desert Reach Oral Surgery, and he came today to answer all your questions. Oral surgery is a very unique specialty. Your resume is very impressive. I was reading about you. Your volunteer work was like amazing. The Haiti story, how you volunteered in Haiti after the earthquake, that was something unbelievable. Tell me, why did you become oral surgeon in general, and what motivated you?
Sure. Well, thank you for having me,
Absolutely.
Doctor. This is a real pleasure and honor to be here. I was very excited when we spoke, so I'm happy to be here. I love talking about oral surgery. It's my passion. For me, oral surgery isn't just a job. It's more of a way of life, actually. Years ago, when I was growing up as a child, my father is a nephrologist, my brother's a nephrologist, my sister and my brother-in-law all went into nephrology. Now I had an uncle who is now 99 years old.
Oh, wow.
And, I spent about 7 years of my life in Iran, and the rest of my life I've been here in the United States. My parents moved here from Iran in the late 60s, moved back in the early 70s. So I spent the early years of my life here, and then between 10 to 17 there, and then I came back here. So I've been here ever since then. But during the time I was there, my uncle, who was an oral surgeon, he trained during World War II. So he's 99. He trained during World War II. And I was always very impressed with his pictures. They were always black and white.
Yeah.
But you had all these soldiers that were hurt, and they had to be, fixed, reconstructed. And
completely, yeah.
Back then, obviously, reconstruction was very different. And the nature of warfare, my specialty has been defined by facial trauma.
Yes.
Years ago, oral maxillofacial surgery started out as an offshoot of dentistry. Then later on, medicine came into it. And even now, we do lots of facial trauma. So I still pride myself in being a full scope oral maxillofacial surgeon. I do lots of dental implants. I do lots of wisdom teeth, but at the same time, I still do lots of facial trauma and head and neck reconstruction. After my training, I spent, some time doing a fellowship in head and neck and tumor and reconstructive surgery. And when I was at the University of Miami, and that's always been my passion.
That's wonderful.
And so I try to do everything and stay engaged in my specialty, and at the same time teach and lecture, and that keeps me fresh in the game,
fresh
so
in the
to
game,
speak.
for sure, because everything is changing nowadays.
Absolutely.
There's so many new things coming out every day almost.
Every day I'm learning something new.
Yes, and you're not just dentist, you're actually medical doctor as well. So for our listeners, oral surgeons, there's two types. There's just dentist who did oral surgery residency for 4 years, right?
Correct.
And Dr. Visha actually did 6 years. So you graduated from medical school as well. So you're dual profession, technically dual specialty, right?
That's correct. So
Yes.
as far as the oral maxillofacial surgeons, a lot of oral surgeons decide to pursue a medical degree as well. And at the time when I was applying, that was the norm. And obviously, I wanted to go on and do more of reconstructive surgery. So as far as my privileges in the hospital, and as far as exposure to my medical colleagues, getting the medical degree certainly helped me a lot.
Of course.
And as far as the oral surgery training goes, single degree and double degree oral surgeons have the same training as far as what we do in our residency. But of course, education can only open doors for you. It never closes doors for you. So, my advice to anyone going into oral maxillofacial surgery is, if you're young and you have the endurance and you have the energy, pursuing the medical degree is certainly not going to hurt you. It will only help you.
Yeah.
But of course, you spend the best years of your life in school.
Yeah. Plus, you can do hospital privileges, right?
So I have hospital privileges. I'm now on staff at the local banner hospitals, the local Honor Health, and just recently I was invited to be the oral surgeon on staff at the Mayo Clinic in Phoenix.
Wonderful.
So I'm excited to do some great cases there with the Mayo Clinic, the plastic surgeons and ENTs. So a lot of our trainings go hand in hand and we complement each other, but it's nice when we can work together because we can do great things for our patients.
That's amazing. Yeah. So tell me about your volunteer experience. I read about Haiti. Do you want to talk about that and tell us how did you end up in that whole journey of volunteering?
It's a great story. I was actually telling someone the story yesterday. They said, "How did you end up in Haiti?"
Yeah.
So years ago, when I had finished medical school, some of my medical school classmates actually, and we did 2 years of general surgery together. So in my early years, after dental school and in between finishing oral surgery, I had to do oral surgery. General surgery. So in my second year of general surgery, I connected with some great guys, and they did a lot of trauma and reconstruction. In 2010, I was involved in a car accident where I wasn't paying attention, and I hit a semi-truck from behind.
Oh, no.
I'm lucky to be here.
No.
Yes. I was texting and driving. And that's something that I recommend against. It's never a good thing to do.
I know.
But I hit a semi-truck from behind. I was probably going 90 and he was going 50. They didn't even feel me hit him, but in that car accident, I broke my hand and my back.
And your back.
And my back. But I didn't have surgery. I just wore one of these turtle shells, a white ivory colored turtle shell. But I didn't really miss work. I went to work the next day wearing the turtle shell. But on the weekends, I would always rest. I couldn't exercise anymore. I was training a lot. I was exercising a lot then too. So I think that's what kept me going.
Of course.
Before the accident.
Before the accident. So your muscles strengthened.
Yes. Otherwise, I probably may not have survived the accident.
Oh, wow.
But when I was watching TV in 2010, on one weekend, I realized some of my friends from general surgery that I had spent time with, who are now general surgeons, are in Haiti after the earthquake. And the University of Miami, where I went to medical school and did my oral surgery and general surgery training, had set up a tent hospital there in Haiti.
Oh, wow. After the big earthquake.
Yes. So when I was a medical student, actually, funny enough, my sister and I were classmates in medical school at the University of Miami. Every one of my family became doctors. And it wasn't because we wanted to follow my father's footsteps. He kind of let us decide what we wanted to do ourselves, and just my mom and dad. My mom was an air traffic controller back in the early 60s when it was not a very popular job for women. And so my dad and mom worked hard, and they said, just try to be the best at whatever you become.
Oh, of course, yeah.
And somehow we all followed in my dad's footsteps. They never forced us to become doctors. It just kind of happened.
Nobody became an air traffic controller.
Yeah, nobody became an air traffic controller.
Yeah.
So my youngest sister became a dentist. My two other siblings became physicians. But my sister and I were classmates in medical school. And so at the University of Miami, when we were classmates, there was always an option to go to Haiti for rotations in family medicine. I didn't go, but I know a lot of my classmates went. The University of Miami always had a very strong presence in Port-au-Prince in Haiti. So when I saw the University of Miami had set up a huge tent hospital right outside the airport and Presidential Palace, I thought to myself, that's where I want to be. So, it's a really interesting story. So I contacted my partners at the time. There was 5 of us. And I said, I really want to go for a week. And one of them said, I want to go with you as well.
Oh, wow.
And great guy, John Akers. So then he said, well, we need a plane because all the airports are closed. So he said, let me call around. I have some friends. I've been living here in Daytona Beach because I moved from Miami to Daytona Beach after my training. And I joined a great practice. So we called around and he said, I got a plane for us. One of my friends who has a furniture store is going to let us use this plane. So I contacted some of my other friends. There was another anesthesiologist, 2 orthopedic surgeons, 2 family medicine doctors, even an oncologist.
Oh, wow.
We were also 8 doctors, 3 or 4 staff members, and a couple of dentists. We all packed the back of this plane with lots of supplies. I reached out to all the local hospitals, and everyone donated their supplies. So we went down to Haiti. Of course, I had a broken back. I was wearing my turtle shell. So we landed in not in Port-au-Prince. I'm sorry, we couldn't fly to Port-au-Prince. The airport was closed.
Yes.
So we flew to the Dominican Republic, and we got in the back of a pickup truck, and it was a very bumpy ride.
Oh, yes.
We had 2 trucks. It was an interesting time, but it really makes you appreciate.
For sure.
I
what
we
actually
have
volunteer
in
Dominican Republic as well.
So
as
you
a
know.
dental student. I remember that bumpy road for sure.
But this was very bumpy for a few hundred miles.
Because you go up to the mountains and then you have to...
Then you have to go back down.
We were on the border with Haiti.
Yeah, it was interesting. So we finally got to Haiti, and there was martial law. And it was awful because, a few 100,000 people had died in the rubble underneath. And we got there about 4 days afterwards. So we set up a camp right inside the University of Miami tent hospital. Then a few days later, we found the United Nations tent camp. It was really amazing because the United Nations, every country had set up a tent for their staff and their providers, healthcare providers. Some were doctors, some were first aid, some were EMTs. It was amazing. Everyone had come together to help the people of Haiti.
Amazing.
And so we were doing surgeries, and you'd have to see these photos. It was like what's that show, MASH, where there was a MASH hospital. That's exactly what it was.
Oh, wow.
So I was washing my hands over a garbage can where they were pouring water and alcohol on my hands when we were doing surgeries. We had people that were stuck underneath the rubble, and they had wounds that had maggots in them already. And as an oral surgeon, I delivered a baby there. We were doing amputations because there was such a shortage of doctors. But what's great was that every country in the world had come together to do
amazing.
this.
Yeah.
But the best part of the trip was at the end when we were getting ready to come back, the plane that we had come with couldn't come back.
Oh.
So NASCAR, Joe Gibbs, who's one of he used to be the coach for the Washington Redskins, and he was one of the owners in NASCAR. He sent one of his own planes.
Oh, nice.
It was the Gibbs, the racing team. It was phenomenal.
Wow.
So they sent one of their big planes. It was a 737, the big one,
the big one,
and took us all back. But while I was in the airport, a gentleman approached me and said, I see your T-shirt says Florida Oral and Facial. Are you an oral surgeon? I said, yeah, as a matter of fact, I am. And he said, what's your name? I said, my name is Vishy. He goes, oh, do you have a brother named Varshi? And I said, yeah, I do. He goes, I work with your brother in Texas. We're both nephrologists.
Oh, wow.
Small world.
That's small world.
But he showed me a picture of a lady with a big tumor on her face, and he said, can you help her? So when I saw it, it was a massive tumor the size of a watermelon on her face.
And that was still in Haiti, right?
It was in Haiti. And she said, and he told me, he goes, we tried to operate on her here and she almost bled to death. Oh, wow. Can you come back? And I said, let me see if I can go back to the U.S. and get her a hardship medical visa. And this is during President Obama's term.
Gotcha.
So I came back and I contacted my hospital CEO. We took a lot of call. When you serve the community in the hospitals, they do a lot of favors for you. And I said, would you let me bring this lady back? They don't have any funds. And he said, if you can get her a visa, we will. We will. And, back then it was very hard. A lot of people were trying to flee Haiti, after the quake, because there was a lot of domestic turmoil.
Yes.
So we wrote a letter to the State Department, and sure enough, they offered her a visa. So we brought her back, and she stayed with us for a few months. And we took out this massive tumor. There was I think a 12-hour surgery me and my partners did, and it was a great ending to that trip. So I've tried to do a lot of mission trips, but that was probably the best mission trip I've ever been on.
Wow.
It's pretty amazing.
Was it one of those cases you remember for the rest of your life?
Oh, yes. We actually published it because the tumor was so large, they called it a gigantiform familial cementoma. Oh, wow. We actually published it. It was basically an ossifying fibroma. Which is, a benign fibroosseous lesion of the mandible, or, it can happen in the facial bones. But this thing had grown so much, it basically devoured her face and her teeth were pushed out. She couldn't eat anymore. So we had a big pizza party for her before she went back to Port-au-Prince. And it was just an amazing thing. I've been to Haiti several times.
Gotcha.
After in the Dominican Republic, but now I would imagine, she's living a great life. And I've been in contact with the church that sent us some pictures from her, and she's doing pretty well.
She's doing good? No,
she's doing well.
Recurrence or anything
no recurrence at all.
That's wonderful.
Yeah, she's doing
saving
fantastic.
Lives.
Well, and actually we had a nonprofit foundation way back in the day. It was called Changing Faces, Saving Lives. And, we did a lot of great things.
That's amazing.
We did a lot of great things. So I still try to do as much as I can. I try to teach my kids that too.
Yeah.
To get involved with mission trips. I took my wife and kids on a mission trip to the Dominican Republic through the dental school that I went to, University of Florida. And, obviously sometimes when you go on these mission trips, you have to sleep on the floor because it's nice and cool.
Yes.
There's no air conditioning,
Yeah.
So
I remember when we went to Dominican Republic, one of the experiences, we had like a giant spider. Oh. And I was one of the brave ones. So other girls from our room called me, Olga, go get the spider. And I'm like, I can get any spiders. I'm not afraid of it.
Sure.
The spider was bigger than the size of my shoe. So it was a huge one.
Yeah, I remember they had lots of wild animals there. But it was a great trip. I look forward to going back if I can one day. We'll see. Yeah,
me too. It's amazing to give. It's just such a rewarding experience.
It's even more amazing.
Life-changing.
Yeah, when you can give to people that you know that they can't repay you, you expect nothing in return, and it just makes you feel great.
Absolutely.
There's no reward greater than giving to people that have no other means for help.
Yeah, I remember we did a couple of kids with broken front teeth, and they were always hiding their smile. And then we did a giant, beautiful fillings.
Oh, that's amazing.
And it was life-changing for that little child. They would hug us, say, oh thank you.
We'll all have to set something up and go again.
Yeah, I agree. I'm all open for it. And taking your children is so important because they don't know how good they have it here.
Absolutely. There's no luxury there.
For sure. Yeah, there's a very raw kind of conditions. But that's how life is.
Absolutely, yeah. We did some good things, and I look forward to going again.
Absolutely.
No.
So another question we have. So a lot of moms and dads, like in pediatric dentistry, they ask about wisdom teeth.
Sure.
Wisdom teeth is as soon as they hit 14, 15, even when they get 12-year-old molars in, they're like, okay, they're getting wisdom teeth. I'm like, okay, hold your horses, not wisdom teeth yet.
Sure.
So tell us, do we need to take out all wisdom teeth? Is it case by case? Tell us when is a good timing.
Sure.
When we should not miss certain things. When it's not too late, but it's more complicated on your side. Because me as a pediatric dentist, I can screen them early.
Absolutely.
And I can send them in a perfect timing. When is that perfect timing for you to take care of that?
That's a great question, doctor. So, years ago, the AALMS, our national organization, came out with a white paper, basically guidelines as far as wisdom teeth go. And, there's a lot of benefits from taking out wisdom teeth. Obviously, full bony impactions are certainly they lend themselves to coming out because they lead to pathology down the road. A lot of times it's just simply bone loss on the distal second molar. Sometimes it's dentigerous cysts, OKCs, amealoblastomas all develop in the posterior mandible, and I see it all the time where patients come to me in their 30s and 40s and 50s, and now they have a big cystic lesion in the mandible. And they say, well, my dentist told me I don't need to take it out unless it bothered me, and it was fully impacted. Now, once in a while, I do see patients that have fully erupted wisdom teeth, and they're in occlusion and doesn't bother them. There's really no reason to get them out. But I see a fair amount of facial trauma. Athletes, as I are both involved with professional teams. I work with, all the local professional teams, and I see a lot of athletes with mandible fractures, and it usually happens right at the angle of the mandible where there's an impacted wisdom tooth. Yes. And so it does.
It's like a weak spot.
Yeah, it's a weak spot. It weakens the mandible because you have this massive tooth occupying space. Generally, when I see teenagers, I see 12, 13-year-olds that come in sometimes, and I tell them, listen, There's no root formation at all. Let's wait. There's no reason to get this wisdom tooth out. First of all, it might come in perfect occlusion.
Yes.
And it's more difficult for me to take out teeth that have no roots because they roll
so they
around.
roll around. I heard about that.
Yeah,
That's
so
tricky.
I try to avoid them. Now, once in a while, the 12-year-old patient has a impacted second molar. So their 12-year molar or even 6-year molar is impacted. Then we have to address the third molar to create space. But, years ago when I was, in training, a lot of, there was a lot of controversy. Some orthodontists thought wisdom teeth moved their other teeth after treatment. Some didn't believe it.
I think it was proven that it's not.
Correct.
Right? Yes.
So there was different schools of thought, but we know that the wisdom teeth don't, create crowding in the front.
It's still a common belief because that's number one question. It's like, I need to take
sure
them
is.
out because they're going to make the teeth crooked.
But as you and I both know, the mandible maxilla change shape throughout life. So, we go through changes. But, a lot of times when I see patients with crowding prior to orthodontic treatment, it's a good idea to get the wisdom teeth removed because you're trying to create space. So much has changed. Years ago, we did a lot of bicuspid extractions to create space for orthodontics, but that's kind of a taboo now. We don't like to do that because it creates a lot of facial changes long term. So as far as the wisdom teeth go, I would say most people need them removed, but I like to take them out, obviously, when they're not completely symptomatic. Sometimes patients will come to me and they're in pain because they have pericornitis. We try to clean the area out, irrigate it out, put them on antibiotics, and have them come back a week later. That way they're not working on an infected site. Unless it's has no option. If they have trismus, they have a lot of pain and swelling, then we have to address it. But as you and I both hear about it sometimes in the news, where people die from their wisdom teeth that were not removed. Last year there was a story about a truck driver that was in his 30s driving all the way from Atlanta to Arizona.
I heard about that.
And he had pericornitis for a week and ended up becoming a big Ludwig's angina, and he didn't survive that. So, impacted wisdom teeth can lead to infections, and those infections can be avoided. So overall, my recommendation is to at least have the wisdom teeth evaluated to see if they need to come out. So it's more of a case-by-case basis. I don't like to remove every single set of wisdom teeth because sometimes they're in perfect function because, I'll see adults and their wisdom teeth are in perfect occlusion because they had bicuspid extractions at a young age, and now their wisdom teeth have moved forward. So we're mentioning, I think it's a case-by-case basis. But always have them evaluated mid-teens. I'd rather see someone at 15, 14, 15, 16 rather than 25 or 26.
Yeah.
I had my wisdom teeth out in my late 20s. And, interestingly enough, I have right paresthesia of my inferior alveolar region due to oral surgery. So
Is still do? Or?
Yes, 20 years. So
paresthesia, guys, is not be able to feel numbness. Yeah.
So I've been numb. So every time I get work on in the right lower quadrant, my lower right mandible, the mandible, I have to get, even though it's numb, but it's painfully numb. So when I shave, it tingles and it's funny. When I get a cleaning, the ultrasonic sends me through the roof. So, it's better to take out those teeth when the roots are a third of the way formed, not when they're fully formed and have room to get around the nerve. So when I had my wisdom teeth out, we didn't have a CT scan in dental offices, right?
Yeah, that's right.
Now, every oral surgeon should have a CT scan, just like every orthodontist and pediatric dentist does. That way you can evaluate the position of the nerve. So, at 16, there's virtually very little chance of damaging that nerve taking out wisdom teeth. But at 25 and 26, there's a higher chance. And that keeps on increasing as we get older and older. So when I see someone in their 50s and 60s, I tell them, there's a good chance you could be numb.
For the rest of
but now the wisdom tooth has caused a big cyst or it's fractured, so we have no choice but getting out. So I always tell them, I'm like, make sure you bring your children in, and if they've already had it done, make sure your grandchildren have it done as well, because you never know what's going to happen.
What's going to happen, And tell us how you guys handle now after surgery. So I remember back in the days, dry socket was like the biggest complication.
Absolutely.
And it still is, I believe, in certain cases. But now I hear about those new medications you place,
Sure.
also in plasma and so
Absolutely.
on. So tell us more. Stem cells, right?
Absolutely.
So
So,
what has changed since?
a lot
the
of
past-
things have changed. When I was first out of practice, I joined a group practice in Daytona Beach, and my two older partners, they never sutured any sockets. They said that way stuff can get in, can get out. But then I would have some patients, I would see them come back with infections. I sutured every single socket, top and bottom, and I still do. And I would see less dry sockets. But of course, one of the things that I like to point out is if your surgeon is skilled and has been doing this for quite some time, they can get through the procedure a lot faster. And there's less trauma to the area, and that becomes less pain post-op and less complications. So if a procedure takes an hour and a half to 2 hours to take out wisdom teeth, then
That doesn't sound good.
but it happens all the time.
Oh, really?
Of course. I mean, not in most oral surgeons' practices, but sometimes I'll see a patient that was referred to me from an outside office, either an oral surgeon or a general dentist or periodontist was doing the procedure under local anesthesia in some office. Because as you and I know, there's a lot of traveling doctors now. I call them itinerant surgeons. And, if you're traveling from office to office, you don't have all your tools, the right assistants. And, you see the patient for the first time, day of surgery, you're doing a procedure, and it takes forever. I do a lot of nerve repair as well, and we'll get to that in a little while. But, there's higher complications when procedures take longer. But for all my lower sockets, I always take PRF. So years ago when I was at the University of Miami, we developed, my mentor, Dr. Robert Marks, he did a lot of stem cell and bioengineering. And we started using PRF and PRP.
Can you tell our listeners what is
Sure.
PRF
So
and PRP?
platelet-rich fibrin and platelet-rich plasma, they're pretty much very similar. Very similar. It's just we use them for different purposes. So we basically draw 10 to 20 cc's of blood when we start an IV. So almost 99% of patients that I work on are sedated. And I have a full-time medical anesthesiologist that works in my office with me. As an oral surgeon, we have the training to do our own sedation. But over the last few years, there's been some instances where complications have arisen in different offices. So most oral surgeons are now, hearing about, from different boards and different societies where the two-provider model might be safer, and I think that's something we're gradually moving towards over the years. So I kind of jumped ahead of the curve and hired a full-time anesthesiologist.
Wonderful.
And so he does all my sedations. Unless he's on vacation, then I do my own sedation myself, and just to remember, and I remember how to do it. But a lot of oral surgeons still do their own sedation, and we have the training to do it. I just like to concentrate on surgery alone. Instead of doing surgery and anesthesia.
Working with kids, I always worry when I refer somebody to oral surgeon.
Kids and adults,
especially adults with complicated medical history, and children when airway is very unpredictable.
So it's nice because I don't have to worry about it at all. But years ago when I was at the University of Miami, we did a lot of research with PRP, platelet-rich plasma, and where we were growing bone in areas of defects in the mandible and maxilla using cadaver bone to mix it with. Because, when you're trying to do a bone graft or create bone in a sinus or in any area where you've extracted a tooth, you can take autogenous bone from the leg, but nobody wants you to harvest bone from their leg anymore.
Of course,
So, or from the back of the mandible, or you take cadaver bone, and which is all just a matrix, there's no live cells. And you're adding live cells by, drawing some peripheral blood, spinning it down, and taking all the platelet-derived growth factors. There's platelet-derived growth factors, there's stem cells. There's a lot of good material that help grow bone, help soft tissue heal. So we would mix the PRP with cadaver bone and grow bone. Then later on, a lot of our colleagues started using the platelet-rich fibrin. So we basically spin it down and create a plug with lots of growth factors in it. And I lay it in the lower third molar sockets and I suture it closed. I honestly can't remember the last time I had a dry socket.
Wow.
It's been quite some time. So some oral surgeons are now gravitating towards using the PRF, and we just include it with almost every single case.
Wonderful.
And I see far less complications, by using PRF in the lower
PRF.
sockets. We don't use it in the maxilla at all because I don't want it to float away into the sinus. And oftentimes you're not drilling at all in the maxilla, so you don't really need to worry about that.
Gotcha.
But yeah, the shorter the procedures are, the less complications I see. And now that we use PRF, it's even better.
And dry socket kind of getting
It gets
technically
less and
becomes
less and
less.
The less I have to pick up a handpiece, or the shorter the cases, the less the incidence of any complications, especially dry socket as well.
Socket. We usually don't worry about dry socket in children, but if we do adult tooth extraction, what do you think? For example, completely like broken 6-year-old molar.
Sure.
Would it be beneficial for a child, or do you think they have enough like blood flow?
Well,
to just close
children
that?
have a lot more circulating stem cells. Obviously, that's why children
course.
heal so much better from nerve injuries
Yeah.
or any kind of injury, or even their facial trauma. I think unless there's a large defect, a large like bony defect, I don't really use the PRF in children a whole lot. Unless I'm dealing with a big cyst, like I'll see a child come in with a large cyst in the mandible that I've removed, and I just basically put PRF in the defect.
Then it makes sense,
to kind of.
But on a
act as
daily
filler.
basis, you would say, like for adult tooth extraction, doesn't need
No,
it. That's what I thought.
not on a regular basis. I don't use it in kids.
So talking about technology, you mentioned CT scans. How
Sure.
common is that? You've been practicing so many years.
Sure.
So when CT emerged, how much does it help you? And we still have people who don't use CT scans.
Sure.
And we have oral surgeons who use CT scan. How did it make a big change in your practice?
I mean,
What's the difference?
It's a tremendous difference because, I know practices here locally in Arizona, oral surgery practices that didn't have a CT scan until just a couple of years ago.
Wow.
And so like 2023. So I first got a CT scan in my practice in 2004.
Wow.
When it first came out, because it's a game changer. Imagine, when we look at a Panorex, remember it was in our training, they would put a Panorex up, and it's a two-dimensional picture.
Plus it's kind of squished out.
Yeah, it's all squished, and it's a three-dimensional object. You really don't see anything.
No.
And it hides a lot of information. The CT scan gives you so much information. You just have to know what to look for.
Exactly.
And I pride myself in having a CT scan in my practice. I've had it for 20 years now
20
because
years now. Wow.
every case that you do, and you compare the Panorex to the CT scan, there's so much information that you could have missed from a Panorex.
Special pathology, probably.
Oh, absolutely.
Right?
Pathology,
Because you can't even...
3D inclination of teeth. Patients come to me and for an orthodontic surgery consultation, and their teeth are perfectly straight, and they just finished their ortho. Then I look on the CT scan, and there's no facial bone at all, right? So the case was finished orthodontically to mask their skeletal deficiency with dental compensation. And I tell them, hey, we're going to have to do some decompensation here to get you ready. And, there's a lot of things that we see, like with impacted canines. I'm sure you see it a lot in your practice.
We do.
Where patients come in, young kids with impacted canines. Sometimes all four of them are impacted, which is quite unfortunate.
Yeah.
Usually I see it more in the maxilla.
Maxilla, yes.
But, impacted second molars, canines, and like you said, pathology. And, remember back when we were training, we did it with a plain film. You had the slob rule, same lingual, opposite buckle.
Yes.
Nowadays, I would imagine the
need to
younger
worry about-
dentists wouldn't even know what a slob rule is.
rules, yes.
I mean, they read about it.
Those P's, yeah.
But the days of just taking out teeth with periapicals and doing implants with a periapical is over. And in some states it's still not below standard of care to do an implant with just a plain film. But and I'll see once in a while, because I have lots of colleagues overseas and they've done x-rays on a implant afterwards, and they just used a PA or a Panorex. But I just can't imagine it, because I'm only seeing, imagine if you can only read one page of a book and they ask you, how was the book?
Exactly.
You have no idea.
Yeah.
So I think it's very important to have all the information. I can't imagine not having a CT scan in my practice.
Yeah. Talking about the overseas, a lot of patients nowadays trying to do like a budget surgery.
Oh, for sure.
So they're flying to, I mean, common destination is Dubai, for example, Turkey. Sometimes even on your Instagram, some kind of feed pops up with all of a sudden everywhere. Like they're flying to Mexico and it's a trip, it's vacations / oral surgery. Do you see a lot of people coming back with complications?
I'm absolutely. So it's interesting. That's a great question. I see a lot of patients that go down to Mexico or South and Central America for work. And I have amazing colleagues, friends that are oral surgeons or general dentists or periodontists in all over the world, all over the world, in Brazil, Argentina, Mexico, and even in Europe and the Middle East, like Dubai. You just mentioned Dubai.
Yes.
It's not usually these guys that are seeing the people going there for medical tourism. A lot of times it's these clinics that they set up. It's very similar to the groups we see here. We see a lot of practices now. Dentistry has been engulfed by private equity and big DSOs.
DSOs, for sure.
And I can tell you with absolute certainty, the quality of care that you and I provide as private practitioners in a boutique style practice is superior to any kind of private equity or DSO or chain practice.
For sure.
When I first got out of residency, I went and worked for one of those DSOs. They promised me the world.
Me too.
And lots of money. And after 6 months, I couldn't take it anymore.
Yeah.
I didn't care how much money I was making. I resigned. I said, I can't do this anymore. And for me, it's the best competition. So here in town, there's a Nuvia Dental Implant Center and a Clear Choice right next to me. And there's so many of these chains, Affordable Dentures, Aspen Dental, and that's fine. They're great for some people.
Yeah.
But, and they're very similar to those medical tourism clinics that you see in Mexico or Turkey and all those places. For some people, it worked great. But when things go wrong, they're not equipped to deal with some of those complications. I just recently had a patient that I'd seen for a consult. I do a lot of all on fours.
Yes.
My practice is completely digital. We have 5 3D printers. We do photogrammetry. We don't take impressions for implants anymore. It's all scanning. So I had a patient that I had seen for a consult, several of them, and they said, well, I can get it done for half the price in Mexico.
Yes. We get this question.
So I tell them, a lot of people go to Mexico to have veneers done or braces done.
Yes.
And so, sometimes it works out great.
Some doctors are great.
But when it doesn't work out great, you're in big trouble. So I recently had a patient, went down there for implants, and they all failed.
All
of them failed. And I said, we gave you a quote back then, and it was something like $40,000. And you went to Mexico and had it all done for $15,000. Now you've wasted all your money there. You went and stayed there in a week for a hotel. They didn't give you anesthesia. He was awake for the whole procedure.
Oh, wow.
It was awful. And so now he's got to pay to have it all redone.
And it's more complicated now because it's already bone loss and everything. Failing implants is no joke.
I had another patient who wanted full mouth veneers, and I referred him to one of our mutual friends.
Okay.
And he's like, oh, it's too expensive. I can get it done for a third of that price in Mexico.
Okay.
I was like, okay. So he went to Mexico, and they did all these veneers, and some of the teeth got overheated. They had to get root canals. When they did the root canals, the sealant material went into the mandible and the inferior alveolar nerve, then the patient became completely numb. So as a result, painful paresthesia. So then the patient needed to get nerve repair done. And that is not
so sad.
And a cheap procedure. So he had to be hospitalized, and he regrets having to do that. I had another patient who went and had a nerve repair done elsewhere. Another ones are the patients that have orthodontics. They go down there for orthodontics. They don't treat the second molars at all. It's not an area of interest to their orthodontists. But now, they come back and their mouth is a complete mess because they've moved the teeth so rapidly. The roots on the anterior teeth are completely gone.
Yeah, we see that
and
too.
they tell me, look at my smile, it's beautiful. I said, yep, your teeth are moving. So I tell patients now, yes, you can always go south to get the work back done, but then you have to come back up north to fix it if it goes wrong.
Oh gosh.
But like I said, I have great friends. I have a few friends that are working in clinics in Dubai and Abu Dhabi. We almost did that ourselves years ago.
Oh, wow.
We were approached by the royal family in Qatar.
Oh, wow.
Because they said, the World Cup is coming to Qatar, and we want to open a multi specialty clinic in Doha. Would you guys be interested? And it was me and 4 other doctors. It was a general dentist, an orthodontist, a plastic surgeon, a dermatologist. And we went there and visited. I actually went there with my father to visit. And it was a beautiful country. But I thought to myself, well, who's going to do the follow-up on these patients? So that's another topic.
Yeah.
The follow-up
is critical.
So imagine you go to Doha to get an all-on-4 done, and you come back to another country. You go to your country, and now you have a problem. So, they said, well, we want, either one of you is always living here, and that's not really practical.
Of course,
So, but even if one of you is living here, if you go back home to Germany, let's say, or come to the U.S., now you have a problem. Now who deals with that problem for you?
Exactly.
You're going to have to fly back. So the money you saved on getting the procedure done here, and now you have to spend again to go there to get it done. The technology is great in a lot of these countries, and medical tourism can be good, but it's not always good.
It's not always
so
good.
As a general rule, I avoid it. I don't recommend it. And the craziest story I just came across not long ago, these 2 young ladies went to Turkey for a mommy makeover, a full mommy makeover, right? And as you know, in the Middle East, and there's a lot of organ sales. Kidney sales is very popular, right?
No, I didn't know that.
Oh, yes. So people pay a lot of money for a kidney. Kidney transplant is one of those things where here people get on the waiting list sometimes a year or 2 years.
Yeah.
So imagine if you need money, you can sell your kidney. So it's unethical. It's an unethical practice to do that. But in some of these countries, if they can steal your kidney. So let's say you go in there for a tummy tuck and you wake up, you don't know your kidney's gone.
Oh,
so that's happened here where patients have come back to the States, they had an infection, they got a full body CT scan and their kidney is missing.
Oh my
God. It's not one of those things where you're going to expect to happen with oral surgery.
Yeah.
But if you're having
anything done,
like you said, anything done,
body.
like if you have nerve damage, now you have to come back up here to get it fixed because they're not equipped to fix that.
Yeah.
And so, like I said, there's some place for everyone. So when patients come to me, I have a lot of referrals from Clear Choice and Nuvia and Aspen Dental and Pacific Dental Services. I started out in one of those corporate places. I only lasted 6 months. I couldn't do it. But there's a place for everyone. Everyone can go somewhere, because a lot of those practices, they take lots of insurance. So people want to use their insurance so they can benefit from going there. But I always caution people about going overseas.
Yes, because it's so far and there's no, to lose your kidney.
Well, there's no recourse. Imagine,
really...
so this gentleman that had nerve repair done after all his veneers, I told him, I said, did you try to get your money back from the clinic in Mexico? And they said all of a sudden they wouldn't take his phone calls anymore.
Of course.
But there's no refund.
Yeah, there's no refund.
Yeah, you can't complain.
Non-reversible.
Yeah, it's not reversible. There's no lawsuit or anything like that. There's no board complaint.
Yeah.
So
here is more control environment. So
absolutely.
If something goes wrong, we all first of all know.
Well, we have to answer to someone.
We have to answer to somebody. Yeah. There is a wild.
There's no recourse like that in some of these countries.
Some of these countries, especially I don't know, this new beautiful clinic in Dubai, because I know some friends from Eastern Europe.
Oh yeah.
They go all Dubai, Turkey, and then you hear horror stories about the complications.
I'm sure. I'm actually lecturing in Dubai in January.
Oh, wonderful.
I'm lecturing in Abu Dhabi in February, and then in Turkey in May. So they have lots of great doctors that are, there's great destinations. It's a beautiful place to go.
Yeah.
It's a great place for medical meetings. So when I go lecture at these places, there's doctors from all over the world coming there for the meetings. But I wonder how many of them are local doctors. It'd be interesting to find out.
Yeah,
but they're great places to visit. But like you said, if you go anywhere, it could be the best clinic. Like, you and I can have a patient come from Germany for dental work. But if they have a problem when they go back home, now what?
There's nobody to fix
Yeah, now there's no way to see them. So I always
sure.
try to tell people, trying to get the work done somewhere local, but if it's so ultra specialized that you have to go somewhere, make sure they have some way of helping you out when something
And
goes wrong.
follow-up care, yeah.
Yeah.
You mentioned the technology.
Sure.
So AI, now everybody's talking about AI. What do you think about, like, how do you implement that in your practice?
Absolutely.
In particular, and what do you think in the future? Would it be like all robotic surgery and dentistry is gonna just disappear? What is your opinion on that?
No, I don't think so. I actually, that's a great question. You and I will never go away. I have a robot. It's something called, it's called the XNav, Yomi, and Navident. All
Yes,
these
I heard
companies
about
have it.
those. Yeah.
So I have one of those in my practice, and there are limitations. First of all, it's big and bulky, and you still need to operate it. You have to tell it where you want the implant to be, and then it'll stop you from placing the implant somewhere else. So you can't go wrong, but you still need to provide information to it. So even in general surgery, they do robotic surgery with the Da Vinci, but you still need a person to operate it. So where AI really comes into place in my practice now, we use facial scanners to, when I want to recreate someone's smile. Let's say a lot of my patients come to me, they're older, they've lost their teeth 30, 40 years ago.
Okay.
Their faces collapsed, their vertical dimensions collapsed, and we want to basically create something that looks natural. And youthful for them. So before, when we did these kind of full mouth rehab cases, we were placing the implants, taking a denture, hollowing it out, and attaching it to the implants, and like, hey, that's a lot better than what you started with. But there was nothing natural and beautiful about that. Now, with virtual surgical planning, I recently wrote a few books. Okay. So I'm the editor for the Clinics of Oral Maxillofacial Surgery of North America and the Atlas of Oral Surgery of North America. And, through my years of lecturing, I got to connect with some of the best surgeons and prosthodontists and general dentists in the world. So awesome. I invited all of them to write chapters. So we just recently came up with these books about digital dentistry and graftless solutions. We have one more coming out, solutions with grafting. But I have friends from all over the world, from Russia, from Germany, from Spain, from Brazil, that have all contributed to this. And almost everyone now is using AI to their advantage.
Oh, wow.
Yeah, all of us are. I mean, the good places are. So when I do a case, let's say if someone comes in there, and like I just had a patient come in from Florida last week, who her dentist had seen me lecture somewhere, and he said that he didn't feel comfortable sending his patient to anyone in Florida to do this. And literally, it was a very difficult case. And obviously, if there's a problem, I have lots of friends in Florida who can see her for follow-up.
Yeah.
But she came to me and she had been without teeth for 30 years.
Oh, wow.
And we did a smile design. So we take photos. Nowadays, we do 3D intraoral scans, 3D facial scans, and a CT scan. And we send all this data to the software. It's called ExoCAD and ExoFace. And we use a lot of artificial intelligence to create a smile. And we can show it to the patient.
Oh, wow.
The same thing with jaw surgery. We use the Dolphin Imaging as a software. But I use some companies' products called MedCAD. And so where we do is a lot of these companies, when I want to do orthodontic surgery, we recreate what we're going to deliver to the patient so they know ahead of time what they're going to look like. Back when I first started doing this, we would draw on wax paper or position, moving the jaw like this and like that. And this is how we think you're going to look.
I remember looking at the pictures from before when we did dentures. Like, that's how you used to look. You want to look similar to that.
So
now it's all like
all
virtual.
inclusive
and virtual, and you can actually.
There's a lot of virtual surgical
amazing.
planning.
That's such an amazing service to a patient.
It really is. So back when I trained, so I have had to stay up to date with that. A lot of surgeons that get a little bit older, they're like, "Wow, man, this technology is really crazy." But some surgeons stay up to date. They go to continuing education.
Yeah.
You almost have to. You can't.
You have to, because you get obsolete so
Otherwise,
quick.
you fall behind the curve.
So behind.
So when I did jaw surgery back when I was in training, we would buy wax paper. I had my blue pencil, my red pencil, and all these colors. We drew angles at vernacular angles. Nowadays, it's all done the click of a button, digital.
That's amazing.
So obviously, if technology ever fails, then you're in trouble. But generally, it doesn't. So AI is tremendous. It
That's
shows our patients what can be done ahead of time. And we can make changes ahead of time, not after the fact. That's why it's so powerful. But I imagine that it's going to get even better.
Wow.
But I don't think it'll ever replace us 100%.
Yeah. Hopefully not. Hopefully
Yes.
we'll have our jobs. My behavior management techniques would, I don't know what AI can do that.
Like, that movie I, Robot, where the robots replace people.
Yeah.
I don't know if we'll ever have an eye dentist.
Eye dentist.
But we never know.
Well, I can see that DSOs, for example, placing those like robots everywhere, and one dentist is just like supervising everything. I mean,
sure, but
right?
But you and I probably wouldn't go to them. I mean,
we wouldn't, but some people with
might.
insurance issues or saving money, we're back to square one, and
absolutely.
Then who knows what the robot does?
Yeah,
that's kind of, I don't know, futuristic, but possible, right?
But I know in our lifetimes, it probably won't happen yet.
Hopefully.
Yeah, hopefully it won't happen where we get replaced.
But our children, we don't
absolutely.
know.
I mean,
could be.
I mean, the young children going to dental school now. Two of my dental assistants that had worked with me for several years started dental school this year.
Oh, congrats!
Yes,
that's
they're fantastic.
Wonderful.
Yeah, they were great, and we miss them a lot. But I'm really interested to see how their education compares to mine from 20-something years ago.
Yeah.
Because
that would be interesting to see. Yeah, if the dental school keeping up with all the new technologies and everything else.
Well, I wonder if they're teaching the old stuff.
Because the old stuff is important too.
Sure.
Absolutely.
I think it's important to know how to mount a cast.
Yes.
To learn about articulation.
They might not teach that anymore because of the scanners. What do you think?
And everything has changed. I mean, who wants to mix
I remember
impression
those
material?
golden inlays we had to do.
Oh, yes. I remember when I was a child, I hated going to the orthodontist because they were going to fill up this tray and stick it in my mouth and take an impression.
Now it's completely
Nowadays,
absurd,
that's all gone. So going to the orthodontist, going to the endodontist, going to anyone is more fun.
Absolutely.
Absolutely. I think so.
Yeah, all the problems are completely different now. So we don't know.
You better believe it.
We better believe it. Another question I have for you. What about like medications? Now we hear about antibiotical resistance.
Sure.
And I remember in dental school, penicillin was still like a golden standard in dentistry in general. So if we have, what is there any changes from
there
preferred
are
medications?
Sure. So, I mean, that's a great question. So penicillin and amoxicillin are great for oral flora.
Yes.
And they give you the best coverage against the aerobes, some of the anaerobes. But, most of the big infections in the oral cavity and head and neck region have some anaerobes. So then you have to take penicillin or amoxicillin and add clovinate to it or add something else to give you a broader spectrum. But I don't routinely give every patient antibiotics after an extraction, but now if there is an infection, my antibiotic choice is the penicillin family.
Still penicillin.
Oh, absolutely.
So we still don't have that antibiotic resistant medical doctors worry about.
Yeah, well, some of them do worry about it, so they recommend clindamycin, but we have to be very cautious with clindamycin because at the lower doses, it's bacteriostatic, it's not bactericidal. And then clindamycin has been shown, that leads to more dental implant failures, leads to more non-healing bony sockets. So as a general rule, we see, and there's studies that have come out that show higher dental implant failures in some patients that are on hormone replacement therapy, or especially with the clindamycins.
Interesting.
So I don't really use clindamycin in my practice. And unless it's absolutely...
In pediatrics guideline come out with no clindamycin as well.
So, and it's one of the reasons is the higher incidence of, it inhibits certain bony healing, like with the osteoblasts and osteoclasts. So what happens is with these patients, they have delayed healing.
Mm-hmm.
But we certainly see a higher dental implant failure rates.
With
So if someone's
clindamycin.
allergic to penicillin and they can't take penicillin after a bone graft and after a dental implant placement, I would rather not give them anything. If they can't take penicillin, then give them clindamycin.
Would you do Z-Pak?
Sure, absolutely.
Yeah.
So I would give them Z-Pak, or I give them a fluoroquinolone like Levaquin,
Yeah.
even though the coverage is not as great. But with Z-Pak, I'm often careful because with the macrolide antibiotics, with Zithromax or clarithromycin, some people get bad GI upset.
Yeah,
I
do.
personally, I can't take Zithromax myself, but some people take it for sinus infections and allergies. So there's always options. You can give them Keflex, even though it doesn't have great coverage in the mouth. Like the cephalosporins, like Keflex, they give you great coverage on the skin, but
not in the mouth.
not in the mouth as much. But it's still better than nothing, because it only has some gram-positive coverage, but no gram-negative or anaerobic coverage. But I almost think that anything is better than clindamycin in the mouth.
Plus, clindamycin destroys your
Oh, absolutely.
GI tract
It
as
certainly
well.
can.
Yeah.
Yeah. So I have patients complaining of that as well. But more is the non-healing and the higher implant failure rate.
Than
And those
anything
studies
else.
just came out in the last few years.
I didn't know that. That's very interesting. Yeah, good to know.
So I rarely use it.
What about, tell me about like your favorite cases that you did. I know that one volunteer one is probably one of the, but I talked to one oral surgeon and a long time ago, and he had a drug addict patient who used cocaine and nose collapsed and the cartilage was completely destroyed.
Sure.
Have you seen cases like that? For me, it was like shocking.
Absolutely. I just recently had a patient who I saw as a referral from one of my other providers, and the patient had chronic cocaine use, and she had developed a very large oral nasal fistula. And so anything she would drink would come out of her nose.
Oh, gosh.
And over time, her nose completely collapsed. Completely collapsed. So what's interesting is I closed the palate and closed her oral nasal fistula with rotational flaps in the mouth. It worked very well. Now, her nose was beyond my skills or anyone here that I know. So I sent her to Dr. Paul Nassif, who's from the show Botched.
Oh, okay.
Yeah, so I had talked to him. I said, is this a case that you would take on? And he said, yeah, it's very unique. But I mean, her nose was completely gone, collapsed.
Wow.
And I can't wait to show you the pictures of it.
That would be interesting.
Her nose completely collapsed, and I think she just went there a few weeks ago for reconstruction. And I haven't seen her post-operative yet, but I would imagine they probably took some rib and reconstructed her nose, because sometimes they take cartilage from behind the ear, but it's not enough in some of those cases.
Yeah, because
but as far as the uniqueness of cases that I'm doing now, I just started in the last few years doing a procedure called jaw in a day.
Okay.
And I already do lots of all-on-4, lots of zygomatic implants where people without teeth, we give them teeth the same day. Nobody goes home without teeth. And then I developed my own patient-specific implants, because not everyone's a candidate for zygomatic implants or all-on-4s.
Can you tell us what are zygomatic implants? Because our audience might not know what is all-4s, because they don't know this terminology that is available even.
So years ago, what we did for patients without teeth is we would do big bone grafts from the hip, reconstruct them, or do these sandwich osteotomies, do a Lefort down fracture, pack bone in there. It works sometimes, but people have to go without teeth for a long time. So then in the early 2000s, Dr. Paulo Malo, who I've become friends with now, he's from Poland, and he's a very prominent oral surgeon. He actually wrote a chapter in my most recent book.
Nice.
He developed this technique called the all-on-4. And everyone thought, this can't be, it's too good to be true.
Too good.
I actually thought to myself, I sat in his lecture in 2004 in Austria, and I was like, this is crazy. This doesn't make sense. But now, 20 years later, the success rate is, we've had hundreds of thousands of cases done worldwide every year. And the all-on-4 is a concept where you place 4 implants, you replace a full arch of teeth by screwing in at the 4.
Right away.
Right away.
Oh, wow.
Now, in some cases, there's not enough bone to do an all-on-4, so then we have to do zygomatic implants, where the long implants that are 5 or 6 centimeters that go into your cheekbone, because
Oh,
your
wow.
alveolus is non-existent. Then we started adding on pterygoid implants, going into the pterygoid region to give you more teeth. Some people don't want just first molars; they want second molars. So
Okay.
that's something, especially if they have their full complement of teeth on the lower jaw.
And it's a
So
denture, right?
it's a
Clip-on.
printed denture that screws in and no longer comes out.
Okay.
So I like to call it a bridge. Sometimes we don't have fake gingiva on it, so it's like a real bridge.
Huh.
So that's one of those things that we're light years ahead of where we were 20 years ago. Like I said, I have some friends that still do lots of overdentures, the snap-in dentures and dentures.
Yes.
Because like sometimes patients will go to a clinic like affordable dentures and they want a denture. They can't afford it, right?
Yeah.
But a lot of the patients come to me, they said, we don't want a denture anymore. First of all, we've been wearing a denture for 30 years and it floats around like a fish out of water and it won't stay because the bone is, they put tons of adhesive. The jaw is so resorbed. So some people, their zygomas are so thin, we can't even do zygomatic implants and they have no option. So on them, a few companies develop what we call patient-specific implants. It's basically very similar to a subperiosteal implant. Years ago we did subperiosteal implants, but they were made out of chromium cobalt, and some of them were done great, but it required multiple surgeries. You had to take an impression of the bone, close it up, go back. Now everything's done virtually. So I just wrote a few chapters on that too. And I think in the last 2 years, I've done 15 of those patient-specific implants. I've done more than anyone in the country now.
Oh, wow.
And I designed my own now, and I'm working with a company out of Europe, Germany, to make these. There are other companies that make them as well. They're just very expensive. Some of the companies charge $25,000 to $26,000 just for the implant, which becomes very prohibitive for patients.
So what's the difference between that custom implant to the regular implant?
So basically it's like a framework. It sits and screws into the jawbone, and then it has abutments that the teeth screw into.
Oh, wow.
But, that's been around for a little while. But my favorite surgery now that I do is called jaw in a day.
Jaw in a day.
Where basically, let's say if someone has cancer of their mandible or maxilla, or they had radiation necrosis or a benign tumor, years ago what we did is we resected the lesion, we put a plate on there, and then at the weight, and then they came back and we did a bone graft from either the fibula or the hip, to reconstruct them, let that heal, then we would put teeth on it. It took 2 or 3 years.
Oh, wow.
Now, I think I'm the only person doing it in the Southwest here. There's a few of my friends doing it in Texas, and the guys who trained me are in Texas and San Diego. A couple of great, they're ex-military guys. But they're in the Navy now, and phenomenal surgeons. But they actually also wrote a chapter in my book, and amazing guys.
What's the name of your book?
It's called The Clinics of Oral and Maxillofacial Surgery, and the Atlas of Oral and Maxillofacial Surgery. I'm the editor for it.
Yeah, you guys are going to have link if you're interested.
Yeah, it's great for anyone doing oral surgery.
For all the colleagues of ours would be amazing.
Yeah, and it's great. We got solutions with grafting, graftless solutions, and digital workflows. I talk about all the various workflows. It's just not just my workflow, but I've gotten some of the best in the world to each write their special, the way they do it.
That's
because
interesting.
there's different ways to do things.
Yeah.
So what we do now with these patients is my colleagues here, they're doing the resection of the mandible. It's an ENT and a plastic surgeon working together. I do these at Banner, and now we're going to do them at Mayo. And then I am placing dental implants in the fibula while it's still attached to the leg.
Oh, wow.
So I place 6 or 8 implants, usually 6.
Okay.
And we've already done this virtually. We planned the case ahead of time. The teeth are ready. So we take the fibula from the leg, we bring it up to the mandible, we section it in the right spot, we put it in place, we screw in the teeth. So the patient went to sleep with teeth and with a tumor in the jaw, and they wake up with teeth in place and no more tumor.
And no more tumor. That's like
it's called
futuristic.
Jaw. Yeah, it really is. So it's called jaw in a day.
Jaw in a day.
Yeah, when Dr. Malo developed teeth in a day, or teeth in an hour. It was, replacing your own missing teeth with dental implants. This is replacing the jawbone and teeth
I'm so glad you're talking about it. I'm
Yes.
sure nobody, I mean, there's very few people who know
Not
about
many people
these
doing
options.
it. This year, I've done 3 cases here in Arizona. One was for a benign tumor. 2 of them were for patients that had osteoradionecrosis, and 1 had cancer. So people have options now. You no longer have to go through numerous surgeries. And really, you think about it, that is available to me because of the technology, the
Course,
AI.
yes, AI. Yeah,
So
that's
what
what we
I
were
do
talking
is
about.
I sit down, virtually plan the case with the plastic surgeon and ENT, all 3 of us together. Sometimes they're oral surgeons. So my friends that train me on this are oral surgeons. They do everything themselves. So we sit there, we look at the fibula. I look at what part is better for dental implant placement, and we section the fibula. So basically, we take a straight bone and make it look like a mandible by sectioning and putting screws and plates on it. So patients wake up with teeth.
With teeth. Wow. And their own bone, technically, there's no, like,
It's their own
artificial,
bone.
there's no plastic.
There's no
nothing.
rejection.
That's amazing.
There's nothing.
That's
there.
amazing
And
technology.
the fibula is really not necessary for gait or ambulation, so they're fine. They're not missing it.
Wow.
So I've done a lot of fibula
very, very-
reconstructions where people had the fibula done a year ago, and they come to me afterwards to get their teeth done. So I have to get implants, then wait, then get the teeth. Now it's all
Now
done.
it's all done in one.
That's
That's
swift
amazing.
surgery.
It's impressive. Yeah.
So
I'm
that's-
glad there is options out there for people who are struggling with like
Absolutely.
big problems, like completely missing jaw.
Absolutely.
Can't bite or anything. Tell me about the new implants. They have those ceramic implants
Sure.
versus titanium, right?
Sure.
Traditional ones.
Absolutely.
So it sounds like there's a new movement of this biotechnology, organic and naturopathic. And
Absolutely.
in that spectrum, it looks like people more leaning towards ceramic implants. So what's the difference?
So obviously, traditionally we've always placed titanium dental implants, right? And the surface coating has come a long way. The technology has come a long way. There was a lot of studies that showed that dental implant failures often were because of microfragmentation. There's a lot of studies that came out of different various groups, some at NYU, some periodontists that they looked at under electron microscope. They found that sometimes dental implant failures happen due to shear fracturing of titanium particles. So there was development of zirconia or ceramic implants, obviously. If you look on the periodic table of elements, it's still metal, but it's become a kind of a misnomer where people call them ceramic.
Ceramic, yeah. But it's zirconia.
It's zirconia. It's still on the periodic table of elements. But it's, supposedly better and kinder to the tissue. Now, in my hands, I've been doing them for about 7 or 8 years. Nobel Biocare was the first company to come out with it, but then Straumann came out with it, Neodent and Xeramax. There's a lot of companies that make it. Oftentimes, some of them pride themselves in not having any metal in it, like a metal screw in there. But at the end of the day, there's always a portion of metal in them. There has to be. For it to be radio opaque,
Oh, gotcha.
And
So they are not truly zirconia? They have something in it?
Well, some of them have a metal screw to connect the abutment to the implant, but that doesn't come in contact with the patient.
With the patient bone.
With the actual patients. I've had good success with them. I wouldn't say amazing success because you're limited by what's available right now. The technology is getting better and better. Actually, most recently has been a big shortage of zirconia implants because there's not as many companies that make them, so you can't find them readily. The failure rate is a little bit higher, and the fracture rate is a little bit higher. So rarely do I see a patient with titanium implants come in 2 or 3 years after they've been restored with a broken implant. I've had a couple of patients, young, strong bites that have actually broken a zirconia implant after it was restored. So you have to be very cautious when you select the size. There's less room for error, so to speak. But it's it's kinder to the tissue. There's a lot of studies that show zirconia is better for your tissue and healing. But there's a learning curve to placing them.
Interesting. Yeah. I see in the noise of like root canals failing and placing, for example, implants. So
especially in patients that some patients want to take a holistic approach to their healthcare. They don't want to get root canals. But, and of course, unfortunately, there was a lot of shows like the root cause where they
Yes.
people thought that root canals cause cancer. And we've proven that over and over
It's
that it
not.
doesn't.
Yes.
Root canals are perfectly safe. But it's hard to convince some patients otherwise. And I obviously allow my patients and my referrals to make decisions. I tell them what I think, what I would want in my body, but at the end of the day, I've never told a patient no. As long as it's medically sound decision making, I don't tell them no, I'm not going to do it. I mean, sometimes we tell patients this is not, I may not be the right doctor for you.
Yeah, of
If
course.
you're asking me to remove all your root canal teeth.
Yes.
But I show them scientific knowledge.
I'm curious, since you in this field, you would be the best source for kind of talking about this. So if you see root canals, you don't see tumors of the jawbone later on you see tumors, you said, associated with wisdom teeth,
Sure,
right?
sure.
Impacted wisdom teeth and so on. That's definitely correlation. But I never heard of correlation on the location of the root canal of any kind of tumor associating with this. What is your input on that?
It depends on how you look at it. If the chicken came first or the egg, right?
Yes.
So sometimes I'll see patients that have a cyst in their jawbone, and I'll see all the teeth in the area where root canaled. And I asked them, what happened here? They said, the doctor took a x-ray, so they took a periapical, and all they saw was a big radiolucency. They didn't see there was a tumor or a big cyst in the jawbone.
That's a big mistake.
So they thought it was a lesion, an endodontic lesion, right?
Yeah.
So they did 3 or 4 root canals, and the lesion never went away. And I see that. Sometimes that's really the only time I see it. But
it's not related. Like
No.
the root canals were done not properly because there was a tumor
Correct.
initially to begin with.
But I don't see root canals causing that ever.
Yes.
It's kind of like when patients also have trigeminal neuralgia, and I see someone's taken out all their teeth because they thought they had toothaches, and it was really a trigeminal nerve area.
Oh, wow.
And someone took out because they were like, this tooth is killing me. It needs to go. So when patients come to me, as a general rule, if they don't have a referral from a dentist, then I have to do a lot of due diligence to make sure the tooth is the offending cause.
Yeah.
I mean, we make our own decisions, but if they come from a referral that says this tooth is non-restorable because there's deep decay, I don't take off the crown to take a look because I don't have a periapical film.
Sure.
But our CT scan shows a lot. But sometimes patients will come in with some nerve disorders and they think it's their teeth causing them to have problems and they want to remove.
That's good to know.
Yeah.
Especially
So
in older population.
We see that sometimes even in younger patients with
wow.
neuralgias. Trigeminal neuralgia is often treated with radiation, cyberknife or GABA knife, but sometimes patients think that their tooth is the problem. And they don't realize until after 2 or 3 teeth have been removed that it had nothing to do with the teeth.
Wow.
It was a trigeminal nerve.
Yeah.
Any kind of neuralgia.
Yeah, good diagnosis is probably the key.
Yeah, so being a good diagnostician it hasn't changed. Even with AI and technology, we still have to arrive at the proper diagnosis. And that's why I think you and I will never be replaced by robots because we can make diagnoses.
Yeah. Because, to put all this information in the computer, it still can come up as a wrong diagnosis. What about TMJ? That's something I see on a daily basis, usually young girls or teen girls, sometimes guys, but that's becoming like a very, very big, prominent issue. More and more and more I see in my practice.
Absolutely.
The clicking, painful. And me as a pediatric dentist, I still have to assess the growth and development. So I cannot put some kind of permanent night guard because they're still growing.
Absolutely.
How do you guys handle on the oral surgery side, TMJ?
So I see a lot of patients that have had trauma. So a history of trauma, oftentimes I look into their history to see what's causing it. Obviously, certain patients develop TMJ issues because of systemic issues, like if they have juvenile rheumatoid arthritis or any other systemic issue that the TMJ can be involved in, then obviously we have to address those situations first. But oftentimes I see patients that are going through puberty. And, years ago, actually, I did a lot of TMJ research, and I published this where a lot of retrodiscal pain receptors, the nociceptors, are estrogen mediated. So in a lot of patients that have had TMJ issues at a young age, once they're postmenopausal, they don't have as many issues.
Oh, that's very
But,
interesting.
and these are all studies that are well documented and published. But as far as clinical trials, there's no clinical trials. We're not going to ever remove someone's ovary to see if the pain goes away. But a lot of it's estrogen mediated. Just like autoimmune diseases is more common in females. I see more TMJ issues in females. And I often tell the patients and parents that a click itself, we don't treat a click.
Don't treat it, yeah.
As long as it's not symptomatic, we don't want to treat it. And I always look to see if the disc is a problem or is the bony changes. Oftentimes I'll see people with cortical thinning, their cortex is thinned out, the joint itself has remodeled due to a tumor or real trauma. At that point, we have to treat those patients. But depending on their age, we'll treat them with a night guard, or we'll treat them with physical therapy. I don't like a lot of appliances because I see patients that have had sometimes anterior discluding appliances, or they have sleep apnea appliances that pull their jaw forward, open their bite. So if anyone's doing mandibular repositioning devices or anterior discluding devices for any cause, the dentist, they have to make sure the patient's occlusion isn't changing drastically, because sometimes patients will come to me with a big open bite and the only thing they did was wear an appliance.
Oh, wow.
But now the retrodiscal tissues have come forward, the joint position has changed, and they can no longer bite their mouth closed, and they have joint pain. And those patients unfortunately need surgery.
So that's non-reversible.
It's non-reversible.
Just with appliances.
Just with appliances. So
wow. Because those appliances are so popular now.
They are very popular.
They're prescribed back and forth everywhere for sleep apnea.
And they just need to be used with caution. So if anyone's using appliances, they just need to make sure that they follow those patients very closely. And as soon as they see any changes, signs of changes, they need to stop that or make changes. So that's one of the things. I mean, certainly if someone has obstructive sleep apnea, a mandibular repositioning device can help them.
Helpful, yeah.
But for like obstructive sleep apnea, sometimes patients wear a mask or they have jaw surgery. But the most simple and benign thing to do is to wear a repositioning device. But you have to keep in mind, if you're wearing a repositioning device, it can certainly cause irreversible changes if it's not monitored. You need to see your dentist on a regular basis, whoever's making that.
To make sure,
There's a lot of sleep dentists, and if you're being treated by one, you have to see them regularly.
Yeah, I've seen a lot of like popularity getting also the expansion even
too.
in adults.
In adults too.
And supposed to be healed the airway obstruction, which a lot of controversy about that.
That's
as
also
well.
controversial. I have a few friends that do it, and like I said, as long as you're not so. Sometimes you're just tipping the molars, right? But
that's
if you,
the biggest problem.
and that's the biggest problem. But if you are truly getting expansion as seen on a radiograph in clinical improvement, then that's something that is a positive sign. But once again, I think that needs to be done systematically and slowly. We can't make rapid changes in an adult with well-healed sutures.
Yes.
Because sometimes things will go wrong.
Because they put the TADs and they put appliance which
Sure.
would open up the suture slowly in adults. Like I see as the oldest, like 35-year-olds.
Sure, but it has to be done slowly. It's very difficult.
Yeah, it's very difficult. Yeah.
I recently saw a patient for an impacted canine that had been treated elsewhere as an adult in her 40s. So they wanted to bring the tooth down. As a result of trying to bring the tooth down, she lost all her teeth on the left side. She came to me for zygomatic implants. And so I'm very cautious when I do any kind of bony surgery on adults because the healing is very different. It's far different than working on a teenager where they heal.
But what about what is your input on TMJ surgeries?
So I do a lot of joint surgeries.
You do?
I do joint surgeries when it's indicated. So let's say if someone comes to me and they were at the dental office for 2-hour cleaning like this, and all of a sudden they can't close their mouth. The disc probably went forward. They have a anteriorly displaced disc, which is acute. That we can treat easily with either repositioning or if the disc doesn't want to go back, with arthrocentesis and lavage. But if someone comes to me and they've had pain and symptoms for 3 to 4 years, and I get a CT and there's already bony changes, and then I get an MRI and the disc has been damaged, we know those patients aren't candidates for an arthrocentesis. That might help with their symptoms temporarily, but they need joint surgery. Sometimes if their disc is intact, then you need to bring the disc back and put an anchor on it, do an arthroplasty. But if that's not an option, sometimes you have to do a total joint replacement.
Oh, wow. Do we do joint replacements on
I do,
TMJ?
yeah.
Oh, wow.
So I'm actually doing a total joint replacement in a few weeks on a lady in her late 30s.
Oh, wow.
And she had a big osteochondroma of the condyle. So her condyle is the size of a golf ball.
Oh, wow.
And she has a lot of pain. She can't open her mouth. When she opens, she deviates a lot to one side, and she's in constant pain.
Oh, wow.
So that can't be fixed with appliances. She went to a dentist back at home in New Mexico, and they told her, we can try to control it with an appliance, but that's not going to work. So appliances have their place for the appropriate situation.
Of course.
And surgeries have their place for appropriate situations. So, and that's the thing is, you have to diagnose the patients properly before prescribing an appliance or surgery. Because joint surgery patients, they tend to get better if the surgery is done for the appropriate reasons, is done properly.
Of course.
But if I do a total joint replacement on someone who's a young teenager, which I see unfortunately sometimes recommended,
Oh, wow.
then think about it. If they're only 20 years old,
Oh, no.
that might have to be replaced when they're 40 or
Plus-
when they're 50. And the pain and limitation, because when you do joint replacement surgery, they lose the ability to move laterally.
Oh,
So
wow.
there's a lot of things that I like to, see as far as my data that I collect before I arrive at a diagnosis. Because TMJ patients can be very complex. And all patients come in and say, well, the last guy I saw said he was just going to do Botox. And I say, well, do you have a muscle problem? Because sometimes people have clenching and,
Oh, yeah.
and,
Yeah.
and then we give them Botox. And it works
it
very
helps.
well
Yes,
for
yes,
the
yes.
masseters and temporalis. But if your problem's in the joint, the disc or bone, that's not a muscular
There is not
issue.
much. I remember from dental school, it was one of the most complicated surgeries, and
Oh,
there's kind of
absolutely.
a questionable outcomes.
It's a very small little area.
Yeah.
So you have to make sure that you're treating the right symptom, the right
Right diagnosis.
with the right procedure
Yeah.
or right appliance
For sure.
or
Yeah.
modality.
Yeah.
But it's a very, very,
Very specific,
delicate area.
Delicate area. Yeah, with the questionable sometimes outcomes. Yeah.
absolutely.
So what did we cover? We covered a lot of topics
I
today.
think we covered a lot. One of the
Yes.
things that we do also that we talked about stem cells a little bit
Stem cells.
is
Yes.
where we harvest stem cells from the hip. Now we harvest it with the needle from the tibia, the tibial plateau. We harvest stem cells because here in the blood, when you harvest PRP or PRF, it's some circulating older cells. But if you want to get primitive stem cells, where you get a bone marrow, it's called BMAC. You get bone marrow aspirative cells. Now those are the ones that have the best, the osteoprogenitor stem cells, and sometimes I get that. And, one of my surgeries that I do a lot of is gunshot wound reconstruction.
Oh, wow.
So unfortunately, there are some patients that have self-inflicted or otherwise they get shot in the face. And those are always very challenging cases.
I remember a funny story about that. Not funny, but bad story about gunshot wounds. We had the oral surgery lecture when I was in dental school, and our oral surgeon who was lecturing us told us, if you want to kill yourself, don't go from here.
Oh, sure.
Because you're not going to have a face.
Correct. And you often live.
And you often leave most of the time.
Yeah, I reconstruct a lot of those defects. And now I get amazing results because a lot of it's with the patient-specific implants, a lot of it's with reconstruction. But we can almost make people look as good as new.
Oh, wow.
Almost. No one... With trauma patients, I tell them you're never going to look like you did before this accident, but you'll look really close. And some of the results are just amazing.
I still remember that picture of like a split face after that gunshot wound.
That people look like the predator.
It's so...
But we can reconstruct them now
and put this all together.
With a lot of it together using stem cells. So I use a lot of stem cells.
Stem cells.
And those more complex cases where patients have had bad trauma or radiation, but there's a whole lot of tools in our arsenal at our disposal now that we can use. It doesn't replace good surgical skills and good diagnostic skills, but it helps get much better results.
But with the stem cells, there is a controversy that they can turn into tumor cells or cancer cells.
So
Tell me a little bit more, because I know some practitioners, not in the dental field, but in medical field. For example, if you have shoulder injury, right? So there is a practice in some countries, not necessarily in the US, when they do stem cells injection into the shoulder, and they get amazing results. But in the US, it's prohibited from use. And that form, I guess, right?
So I use stem cells more in patients that haven't had a history of cancer. I do it with patients that I'm going from trauma reconstruction or, a massive defect. But there is some controversy, like someone had a history of radiation for oral cancer. And if you're introducing stem cells into the area or doing hyperbaric oxygen therapy, that you can awaken the cancer cells and cause cancer to come back. Obviously, it's controversial because there is some data on either side of that. I've only had 2 patients over the years that developed a recurrent cancer after either hyperbaric oxygen therapy or stem cell therapy, but because they were both done, it's hard to tell which caused it.
Which caused that?
But there's a very low incidence, but it is possible. Obviously, medicine is always changing, and now we have more and more data available to us. But I'm cautious when I use it, obviously not in children, but obviously in people with a history of cancer.
With a history of cancer. But do we use stem cells for TMJ, for example, to heal the joint?
So what I do is sometimes when I'm doing an arthrocentesis, I have a PRP machine, and we can get clear PRP. We do a double spin. We remove all the red blood cells, and it's clear, and we can inject it into the joint. Initially, it was off-label use, and even now in some places considered off-label use. But if your disc has eroded and it's bone on bone, then you're injecting PRP in there, and it's a protective measure. It doesn't last forever, but it certainly does alleviate symptoms.
Do we see the reconstruction of the cartilage? Cartilage does not go
I don't
back,
think it
right?
reconstructs. No, not that.
Not from stem cells,
Not
right?
from stem cells. You'd have to replace it.
Yeah.
But there are a lot of athletes who had shoulder injuries and knee injuries, and they would get PRP injections into those joints. Not so much into the jaw joint, but I'm treating a couple of baseball players who had bad joint injuries. And I told them, I said, they asked me about PRP because they have friends that get it in their knees and shoulders. I said, we can do it, but it's not a one-time thing where it lasts forever. It's going to be repeated
multiple times.
Because the PRP doesn't last there forever. It's going to disintegrate after a while. So they know that.
And with stem cells in US, we have some limitations, right? Because of the laws, right?
Certain research. More research has to be done in the field. But we've come a long way.
A long way.
We've certainly come a long way.
Are we doing the same thing what other countries do?
Well, obviously with the FDA approvals and certain measures, we are limited. Like, for example, when I lecture at our national meeting, I can't talk about stuff that's not FDA approved.
Okay.
Or off-label. It has to be FDA approved.
Okay.
Well, if I'm lecturing in some other countries, the FDA is not
there.
Not an issue. They have regulatory measures in place, but it's not as strict as what we have here.
Yeah. Very interesting. Yeah, there's a lot of new things developing, new techniques.
Yeah, even some of the technology that I've developed, like the patient-specific implants, some of them are not FDA approved yet. So we are actually getting FDA approval on some of them.
For all of that.
So the FDA obviously is there to protect the patients because years ago there were some bad outcomes due to some, like TMJ devices. Dr. Kent, who's a phenomenal oral surgeon, he developed a prosthesis called the Kent Vitek prosthesis. And, they had Teflon Proplast on him, which unfortunately caused some erosion into the cranial fossa in some patients and major problems. But as a general rule, we don't use Teflon Proplast
Teflon
anywhere
anymore.
else in the body, as far as I know now either. But 30 years ago, that was standard. So the FDA was really put in place for good regulatory purposes.
Gotcha.
And as you know, some other countries don't have the same regulations. But I think that's why sometimes it takes longer for certain measures to be implemented here. But I think it's a good thing.
Yeah, to have some breaks on certain
Absolutely.
things, for sure.
Absolutely.
Anything we didn't cover? Do you want to?
I'm just trying to think that, like I said, our specialty was built on facial trauma. We started out as that. And I think it's great that there's still a lot of colleagues, oral maxillofacial surgeons, that do cover that. Because the way I look at it is, there's a lot of oral surgeons that are no longer full scope practice. They just take out teeth and do implants. But, I have young children, just like you do and many other people do. And the way I look at it is, if I'm taking care of someone else's child someday who either had a dog bite or an accident, hopefully there's an orthopedic surgeon somewhere else thinking the same thing, that if some kid who fell off something and broke their leg, they'll do the same thing.
Yeah.
So I always recommend oral surgeons to all, young and older, to try to stay full scope as long as you can, because you're serving the community that you live in. And that's the ultimate thing. I mean, we all have great lifestyles. We have great, specialties. It's a great career, but at the end of the day, we have to serve the community that we live in as well. So that's always been my goal, is to try to do that as well.
Yeah, for sure. Yeah.
But no, I think we covered a lot.
We did. Yeah, it was very informative.
That was fantastic.
Yeah. Thank you so much for coming over.
Having me.
Yes, and sharing all this amazing source of knowledge with our audience, because I'm sure we're going to have tons of questions.
Well, I hope it's useful for a lot of people.
It's very useful. Even for my profession, it's very useful, because we know what we know, and we don't probably know what we don't.
Well, we're always learning.
Yes, you're always learning,
in our lifetimes, they always say that you're going to learn a lot, but you're going to forget more than you ever learned.
For sure.
Because we relearn and forget and relearn. And so, we forget more than we ever learn.
Yes. Thank you.
Thank you.
I
appreciate it. Thanks for having me.
Yes.
This was fantastic.
That was my pleasure.
Thanks.
And you guys, if you have any questions, please don't hesitate to share this video with all the other listeners who has any kind of oral surgery problems, because I think we covered every single spectrum. I'm sure there's more, and we might do another podcast in the future. Thank you so much.
That would be great. Thanks so much.
Thank you.
Thanks for having me.
Welcome to the Ask the Dentist podcast with Dr. Olga Dolghier, where your smile meets your overall health.